First, there will be two short lectures, very short presentation, one by my colleague, Dr. Mazhar, on the advanced life support algorithm, and another one, unfortunately, by myself on automated external defibrillator. Then the faculty will go forward and demonstrate to you on the first table a shockable and non-shockable rhythm management. Then we will move into the table after and demonstrate to you the use of the automated defibrillator. That's the easy part. Afterwards, you need to move out of your chairs and go to the group given to you on your registration, A, B, C, D. You'll be required to do the following. On one end, you'll be required to show good chest compression and also how to use a back valve mask with 2 fingers on the mask, 3 fingers on the jaw, tilt, and 2 puffs. You do that, which is not very difficult. The instructor will sign, you go back, and your CME will be either ready immediately if you're from outside Qatar or in the time announced for those who are from inside Qatar. The best of luck. I'd like to introduce my faculty. I'd like to introduce Dr. Muhammad Al-Tawil, Dr. Rashid Mazhar, Dr. Muntasir, Dr. Abdul Rashid. Raise your hands, instructors. There's Dr. Hafni, Dr. Mahmoud, Dr. Bahlul, Mr. Rida Miladi, and we have the help of Muhammad Mazhar. We have also the help of Mr. Hamid and Mr. Bashir. Without any more delay, I'd like to hand over to my colleague, Dr. Mazhar.
Assalamu alaikum. I don't know if this works. Oh, it is working. It is working. As Dr. Jahani said, this will not be a recap of the whole treatment algorithm. It's just a refresher and a reminder of the step-by-step actions to be taken during cardiac arrest. And as you can see, you're familiar with this algorithm, aren't you? Yes, so that's finished then. You know this. Well, the thing which I would like to highlight again, look at this part, that is about diagnosis. The first diagnosis, then you start the treatment. And this lozenge here is when your cardiac monitor defibrillator comes in. So clinical diagnosis, then an ECG diagnosis. These are the 2 steps. And there are 2 wings of the management depending on what your ECG monitor will show you. After your clinical diagnosis, when you have done the basic life support, your ECG monitor comes in, and if it shows you shockable rhythm, then you go on to the left hand of the algorithm. If it shows you otherwise, then you go on to the right hand. And in the center of the algorithm are the common actions which you do in all cases. So the very first thing is, do not do resuscitation on somebody who doesn't need it. Make a diagnosis of cardiac arrest. And diagnosis of cardiac arrest starts with the brain of the person. If the person is not responsive, not responding, and with an open airway, if the person is either apneic, not taking breath, or taking very ineffective breath, then your diagnosis of cardiac arrest is complete. You do not need any circulatory clinical parameters to know whether the person is in cardiac arrest or not. Not responsive, not breathing, or breathing very abnormally. So you have made that. So your patient is not responsive, you open the airway, and this is the way you check the breathing for 10 seconds. And if you have made the diagnosis, and if you can, you are a trained professional like all of you, then you can do both of these, checking the pulse and the respiration in 10 seconds at one go. Once you have made the diagnosis of cardiac arrest, call for help. Shout for help, call for cardiac arrest team, and start the basic life support, which is the cardiopulmonary resuscitation, chest compressions 30 and 2 breaths, and get the monitor. As soon you will all be exhibited and told how to do proper compressions. The rate should be 100 per minute, and it should be depressing the sternum for about 4 to 5 centimeters. That's a subjective judgment, and you will do it in an alternate manner, 30:2. Please remember that you will get tired very quickly, so you need to have backup. This is so far diagnosis. You started the basic life support. You have called for the crash trolley, which contains the defibrillator monitor. And this lozenge here, you have got the monitor now, and you can assess the rhythm. Rhythm means the ECG. And this is the quickest way from the cardiac defibrillator monitor. You put up the 2 paddles, put the gel pads, and check for the ECG. And your question in your head should be whether I'm going onto the left-hand side of the algorithm. Is it shockable? Do I need to use this machine? The machine with which you will check the ECG can also give your patient the current, curative current. And that is only needed in a shockable state. Or it is the otherwise. Now there are 4 types of ECGs which you will see once you bring your defibrillator monitor. These are the 2 which you think are relatively better because these are shockable. The first one is ventricular tachy, the low one is VF. Please just take a snapshot of these ECGs and put it on the desktop of your brain computer here so that you can see them with your eyes closed, because that is the key question you're asking. As soon as you put the gel pads and the paddles, you are thinking whether this patient has got one of these 2, VT or VF, then I will use the electricity. I'll defibrillate. If not, this machine is not needed. If it is needed, then you give immediately 1 shock. In this day and age, whichever machine you have, you turn it to its maximum, look out for the safety, and give 1 shock, and immediately restart chest compression for another 2 minutes without knowing or being interested in what is the rhythm, because perfusion will never be up to the mark. Clear? If you continue the CPR, and there is practically when you are doing the CPR, and in the meantime a monitor has come and you have attached it, the waves will be everywhere, so you will say just hold on for a second, look again at the rhythm there, and if it is still the same shockable rhythm, you give the second shock. And you know that your drugs are there, you give your adrenaline before your 3rd shock, and if it needs to be continued, then after the 3rd rhythm cycle of the CPR, you give your amiodarone. If you get a sign of life, patient coughs, moves, gets any movement, and you think, then you will stop and check the pulse, okay? If it degenerates into the unshockable rhythm, then you go onto the right side. Or if you have started and it is an unshockable rhythm, then you stay on this side. On this side of the algorithm, there are only 2 treatment methods. Your mechanical methods, the CPR, chest compression breathing, and some medicines. On the left-hand side, you had chest compressions breathing, drugs, and electric shock. These are the 2 kinds of unshockable rhythm. The lower one at the bottom, everybody is familiar, is asystole. And the upper 2 are the ones where all the confusion arises. Please remember that your patient by now is clinically in cardiac arrest, is not responding and all that which we talked about. But if in a person with cardiac arrest, you see an ECG on the top, like this ECG, which you see and you would expect that there should be a pulse with that ECG. Any type of ECG which is not asystole, which is not VF and VT which we saw, and the person is in cardiac arrest, you call that pulseless electrical activity. It is an unshockable rhythm and you will treat it likewise. In asystole, you give atropine is 1 extra medicine. Adrenaline is given in all kinds of cardiac arrest at the same frequency, 3 to 5 minutes interval. And in pulseless electrical activity, you give atropine only if the rhythm rate, not the pulse rate, rhythm rate is less than 60. Whichever type of cardiac arrest you are managing, in between the cardiac arrest, you think of the reversible causes. We will talk about it in a second. You make sure that your machines are showing what is actual. So you check the electrode position and contact, get the airway secured, the breathing secured, establish an IV line, get a proper monitoring system, and you have people who are looking after the medicine and replacing the person who is doing the chest compression. These are the 4H and 4T of the reversible causes, the commonest being hypoxia. So look after whether the intubation is in the right place or not. The other situations will unfold depending on the history and the clinical situation, whether your person is hypovolemic, has got serious electrolyte imbalance or the temperature imbalance, or mechanical problems compressing the heart like tension pneumothorax, tamponade, or chemical or thromboembolism which has blocked the pulmonary circulation, or person has got any toxic problems. So in summary, your approach has to be organized. First is the clinical diagnosis. You start the CPR, then you get your defibrillator monitor machine, and you check whether your ECG with this cardiac arrest is shockable or not. If it is shockable, without delay you shock that. If it is non-shockable, then you continue with your CPR and medicines as and if needed. If you have forgotten all of this and you are a non-professional, then you consider using the automated external defibrillator. Please remember the reversible causes. Thank you very much. And now Dr. Jahani will talk about the AED. There you go.
Thank you. Thank you so much. That's your blade.
Yep, thank you. And this is your mic.
Okay. Assalamu alaikum. Very briefly, one of the most important new developments in resuscitation, mainly of out-of-hospital cardiac arrest, is the automated external defibrillator. This can be used for in-hospital cardiac arrest in low-frequency areas. For example, main entrances, the mosques or churches or whatever it is attached to the hospital, the lobbies, the waiting areas, and so on. But it's more widely used for out-of-hospital cardiac arrest, because the majority of our cardiac arrests do not happen in hospital, they happen outside the hospital. And one of the most crucial factors that will determine whether the patient survive or not is early defibrillation. That's because the majority of cardiac arrests in adults start in ventricular fibrillation or pulseless ventricular tachycardia. And this rhythm, which is treatable by DC shock by defibrillator, will not last forever. It will last for about 6, 7, 8 minutes. After that, it will degenerate to asystole. So the whole concentration in research in the last 10, 15 years to try and get a defibrillator early to the